Hello, this is Dr. Lenicky recording week 3 podcast. Do not forget that we will have a quiz just like last week. This week we're talking about autonomy and non-maleficence. Alright, the lecture objectives. By the end of the lecture, you should be able to fully value the ethical principles of autonomy and non-maleficence, discuss the components of informed consent, and identify conflicts of interest within physical therapy. This week's topics best fit within Principle 1 and Principle 4 within the PT Code of Ethics. And Principle 1 is that PT shall respect the inherent dignity and rights of all individuals. And Principle 4 is that physical therapists shall provide truthful, accurate, and relevant information and shall not make misleading representations. All right, the first thing we're going to discuss is autonomy. Now, what is autonomy? It's the state or quality of being self-governing. Moral autonomy is the authority or right to make your own decisions. We must respect someone's moral autonomy and respect their ability to live and act on their own. For instance, if you are treating a patient who had an amputation below the knee, and you know that, or you feel strongly that they will have the ability to walk with a prosthetic device and be able to get around without an assistive device at some point, but the patient chooses to not get a prosthetic device and walk around with a walker, you have to respect that. You can educate them on all the choices, but you cannot make the choice for them. And psychological autonomy. It's the competence to make your own decisions and the ability to reason and act rationally. In most states, anyone under the age of 18 is considered to not have this psychological autonomy. Now, realizing that as children age, they probably do have a good say-so in what they want, but by law, the parents have the right to choose for the children. When someone is not in a good mental state, so in other words, they've had a head injury, dementia, maybe developmental delays where they don't have the ability to think rationally, they do not have this psychological autonomy. And sometimes an individual must be appointed to make decisions for them. Right. Within autonomy, there's medical paternalism, and this is the view that doctors are justified in promoting the well-being of patients as defined by the doctor, regardless if the patient gives consent. This used to be the case in almost all situations. Whatever the doctor felt was appropriate is what the patient had to do. But as trends have changed and patient autonomy has become more the norm, paternalism is typically only used in emergency situations, and physicians can justify their actions by stating that a rational person would want a certain amount of care in an emergency situation. There's strong and weak paternalism. So strong paternalism is when you're interfering with the liberty for the purpose of promoting good. So if a physician feels that you may get better just with a placebo, but they're not going to tell you that you're taking a placebo. You may think you're taking a medication that has been proven to help. They're interfering with your autonomy and limiting your ability to make that choice. Weak paternalism is when you interfere with someone's ability or someone's liberty in order to prevent them from harming themselves. I think this is more of a something that we would do in almost any situation. You see somebody walking out into the road and a car is coming, you're going to stop them from walking out on the road. Yes, they have the right to walk out into the road anytime they want, but you want to stop them from prevent them from harming themselves, whether it's intentional or not intentional. So to me, I think these terms sound backwards. To me, strong paternalism should be preventing someone from doing harm, but in ethics world, that is considered weak paternalism, so easily to get those two confused. All right, why have we had this shift in autonomy? So like I said earlier, physicians used to have the right to do whatever they wanted, and patients had very little rights. There's many factors that have influenced the shift, and we're going to talk about just a few of them. The Nuremberg Code of 1946. So what happened with Holocaust victims is they were used involuntarily for research, awfully painful research at sometimes, and there has been a change. And so we're going to talk about the Nuremberg Code in the next slide. Also, social movements in the 1960s and 70s. There was more individualism, and there was more rise in patients' rights. And then feminist ethics. My mom tells a story that when I was born, she was having a lot of complications, and the doctors felt she needed an emergency hysterectomy to live. But they wouldn't do it because they couldn't get in touch with my dad to see if that was okay. And so my mother was bleeding, had just had a baby. It was well before cell phones, and nobody can get in touch with my dad, so they wouldn't do a hysterectomy on her. That sounds very old-fashioned, and I get it that I'm not young, but that was not that long ago. That was in the 1970s. And so things really have changed. All right, the Nuremberg Code outlines rights by individuals who are participants in research. You do not have to know all of these, but I would expect you to understand the important parts, such as participating in research is voluntary, and the research subject has the right to be well informed and to understand what they are doing. Any research should only lead to positive results for society, so you can't do research that may harm someone just to see what happens. If the person is at risk of death or a disabling injury, you should not be doing that research. And at any point that the participant wants to stop being a participant, they have the legal right to that. All right, so along with autonomy, it is not just in a research setting, it is also within a treatment setting. And so many of you may or have, well, you have been in PT clinics, and you may or may not know that when a patient comes in, they sign an informed consent. Now, how well the patients read this informed consent or how much it applies to what you're doing to the patient is going to vary. But information within that informed consent needs to state what is going to be involved in therapy and alternative therapies, the risks and benefits, financial costs, and possibly other information which is often defined state by state. Some states require a medical care standard, and this is information that providers in that region agree is important for the patient to know. Other states require a reasonable person standard, and this is relevant information in how a reasonable person would want to know before making a decision whether to participate in care or not. Informed consent should be voluntary. Okay, a person needs to know that they have the choice to participate in whatever care it is. This can be undermined quite easily with coercion, deception, emotional pressure, tone of voice. And so you have to be careful as a healthcare provider that you are providing enough information for the patient to make a choice. And you can give your medical advice, but ultimately it is up to the patient to whether they participate in medical care or not. And the patient must be competent to be able to make the decision. Right, often there are barriers to informed consent, especially in physical therapy. I wonder how many of you, and we may talk about this in the next class, saw a PT or heard a PT asking for continued consent during therapy. Doesn't happen often, but it should. There's often confusion among clinicians about when informed consent is needed. There's sometimes language or cultural issues, and when patients sign that informed consent before they've ever been seen by a therapist, they don't truly know what they're getting into in therapy and what may be needed. Often, when you're signing that informed consent, an informed consent was written, somebody made a photocopy of it, somebody made a photocopy of that, and so you have a photocopy of a photocopy that may be difficult to read, and the patient's just going to sign it just so they can get back to therapy. Also, it is difficult for some therapists to be able to detect the patient's lack of comprehension. So you may explain it to a patient, they nod, they say they understand, but their actual comprehension may be low. All right, within autonomy is truth-telling, and there is a difference between telling a lie and withholding information. But still, if you withhold information from a patient, you're limiting their autonomy. Failure to report errors to a patient, so they were given the wrong medicine, failing to report that to a patient is withholding information, and that limits their autonomy and to be able to make decisions that would benefit them in the future. I want you guys all to pull out your book and read on page 35, case 3.7, to tell a lie. This may be something that happens quite frequently in a healthcare setting, and we will talk about that when we come to class. Right, within autonomy is confidentiality, and I'm sure you've heard about this a lot. Anything a patient says to you should be respected and kept confidential. And so control over sensitive information is required out of respect for autonomy. Professionals should create a shared understanding that with the public that they will take special care in maintaining confidential information. So the more health professionals maintain confidential information, the more comfortable patients will be with providing them all the information that is necessary for treatment. A relationship of trust is created with each patient, and confidentiality promotes health care. So if so you're a 15-year-old female and you go to your physician and tell them something, and 15 is probably a bad age because we talked about the age for, let's say you're an 18-year-old female, let's change that, and you go to your physician with a personal health care need related to the fact that you think you may have a sexually transmitted disease. You're more likely to disclose that information to your healthcare provider if you know that he or she will keep it confidential. Confidentiality is difficult in physical therapy when we often have wide open gyms where every patient can see every other patient that's being treated at that time. I've worked in places that have 0 private rooms, and I've worked in places that have 3 or 4 private treatment rooms, but the majority of the care is done out in the open. You will have situations where you're going to be working with someone, you'll be working with a patient, and your patient says, "Oh, what happened to that gentleman over there?" You need to make sure that you say to the patient, "I'm not allowed to tell you about other patients. You're welcome to ask him or her, but I can't divulge their personal information." You'll gain respect from that patient, understanding that, hey, that therapist isn't going to go tell my business to other people, and hopefully they will understand the confidentiality needs. I do think confidentiality in physical therapy can be hard, and if you want an example of a case on page 36, case 3.9 is a short story about breaking confidentiality that may open your eyes. All right, refusing therapy. The patient has a right to refuse therapy, to refuse any kind of medical treatment. When something is life-threatening, PT can be considered an unwanted therapy. So if somebody's at their end of life, you feel that you can make them more comfortable. Maybe they just want to spend their last days or weeks with their family. So you must respect the autonomy of them refusing therapy. Now, it does get interesting. I worked in a hospital, a long-term acute care hospital once, and had a physician who kept saying patients can't refuse therapy, and we had to inform him that yes, they do. And he said, "I agree with my patients on the best plan of care, and so if they're not going to follow my plan of care, they need to find another doctor." and that's within that physician's right. I think when somebody is in a inpatient rehab setting and they need 3 hours of therapy a day, if they refuse therapy on a regular basis, they're no longer eligible for inpatient rehab. So they have the right to refuse, but they need to understand if they refuse, they may need to be discharged to a skilled nursing facility. So again, patient choice and patient education is needed in settings like that. Right, so now we're going to talk about autonomy and research, and this falls under Principle 6. Physical therapists shall enhance their expertise through lifelong acquisition and refinement of knowledge, skills, abilities, and professional behaviors. Next year, when you start to perform a research study, you must realize that there are several parts of autonomy when research participants come to be part of your project. And we talked about the Nuremberg Code earlier, and then a lot of these have to do with standards that began with that Nuremberg Code. First, it's voluntary consent. The participants have to be voluntarily there. They cannot be coerced to being part of the research study. Informed consent, and with this you need to tell the participant what's going to happen during the study. What are the possible side effects? What are the risks? And sometimes there are no risks. With my dissertation, students are doing a survey. I still have to say there are no risks to participation, but I also have to let them know that their grade will not be benefited, nor will the students' grades be decreased by participation. They also have the right to know that they can step out of the study and quit at any point. And we talked about competence to consent. So you need to make sure the person is psychologically competent to be able to make those decisions. Right, and now we're going to talk about non-maleficence. So non-maleficence is not inflicting harm. And you've probably heard the medical statement of first do no harm. So that's what we're talking about with non-maleficence. Now within non-maleficence, there is a conflict, there's a theory of conflict of interest. So sometimes there's a situation where individuals have interests that can threaten their roles or responsibilities that a normal person would have. So for example, there's episodic and systemic. Episodic is choices that are made voluntarily that may come up once in a while. An example would be a patient bringing in a gift for a therapist. It may be a conflict of interest if you accept that gift. Whereas systemic would be something that is based on the structure of the organization that is always there and creates a conflict of interest. And I would say in this situation, if you're working for a private practice and the private practice is struggling and they're trying to get the therapist to see the patients for longer so they can charge more, this would be systemic because you're trying, the organization, the entire setting is trying to get more money out of the patient, and it doesn't necessarily have to do with improved patient care. Now when it comes to episodic, sometimes organizations set rules. I've seen where places say as long as the gift is under $10. One place said no actual gifts, but if someone brings in food, you're allowed to accept their food. The joke is that donuts and pizza are always welcome in the PT clinic, but other places say no gifts at all. If you are a therapist and a patient brings something in for you, you need to be very careful about accepting it. If it's food, that's wonderful, but you would never want to keep a patient going longer because you're hoping they bring in food again. So be careful about accepting gifts. It can get you in a lot of trouble. Right, say you do have a conflict of interest. Say your cousin owns a company that sells physical therapy equipment to patients, and you are always referring your patients to your cousin to help your cousin's business. You need to be very careful. So here are some moral responses to having a conflict of interest. You can't control that your cousin owns this business, but you can control how you behave with it. One, you can relinquish that conflict of interest, so you can not refer to your cousin and try to avoid it. You can disclose it. You can tell patients, I have a cousin who has a business. You're welcome to go to my cousin and buy this equipment. Or you can go to any other facility and buy equipment. Or just tell them, hey, here's a list of 10 places. I would suggest you find the person with the best customer service and the best deal and buy your equipment from them. And take steps to make sure your responsibilities are properly met, that you're not referring people out to your cousin that don't need that equipment. I also have worked in a facility where it was a PT-owned practice, and the PT's brother was an orthopedic surgeon in town. They took such steps to make sure that there was not a conflict of interest, that any patient that came to us that was referred by the owner's brother, we had to disclose their brothers, and we want you to know that you have the right to go to PT anywhere in town. We would love to see you. We would love to have you here, but we don't want it to look like the physician was sending you here. The physician also did the same thing on his part. He always said, you know, there's 5 or 6 clinics in town. You can go to any one you want. And so there were steps taken to make sure the patients were not coerced into coming to that clinic. So along with non-maleficence and conflict of interest, reimbursement is a difficult conflict. You always want your business to be great, but you need to make sure that whatever you do is warranted, that the therapy that you're providing is acceptable, and understanding the cost of what you're doing. The PT's primary responsibility is to provide a service to patients at a reasonable cost, within the constraints and respect for autonomy. And these are just several types of conflicts of interest. We talked about physician referral. This is one of the reasons physician-owned clinics seem to be a conflict, because if a physician sends a patient to PT and they also benefit from that referral, it can be very difficult to stay away from a conflict of interest. Equipment and supplies. If you are selling equipment and supplies within your clinic, you need to be careful that you are not recommending needless supplies just for a benefit. We talked about gifts, and with teaching, Medicare B, so patients who are on Medicare and have outpatient coverage, students are not allowed to treat those patients and bill for them. Students can treat them, you just can't bill for that service. So in teaching, you have to be careful that whatever the student is doing, that you're not illegally billing. All right, and summary for today: it is paramount to practice is respecting a patient's autonomy. We should have a patient's informed consent throughout the entire episode of care, and not just signing the paper before they come into therapy that says they consent to care. And conflict of interest can impact physical therapy in many ways, and you need to make sure that you avoid them. And here's our ethical question this week. A therapist in an outpatient clinic goes into the waiting room to see a patient. The patient smells of alcohol, is staggering, and slurring his words. The therapist feels he's intoxicated. Does the therapist treat this patient? So please make sure you go into the link on Question Pro and complete this.